Welcome to the deep dive. Today we're tackling one of the most intellectually rewarding and, let's be honest, sometimes intimidating sections of medical study.
That would be neurology.
Specifically, Chapter 28 from Davidson's Principles and Practice of Medicine.
Right. This is the foundation. And our mission today is really custom tailored for you, the dedicated first or second year medical student.
Exactly. We know that neurology can feel a bit like trying to debug a vast, complex computer system with absolutely no manual.
So we're here to provide the architectural blueprints, the critical systems diagrams, and most importantly, the actionable diagnostic anchors.
The goal here is making sure you don't just memorize isolated facts, but that you truly grasp the logic of localization.
That's the whole game in neurology.
That's the shortcut to competence we promised.
Yeah.
But before we dive in, we need to frame this. Why is mastering this complexity so, well, non-negotiable? What's the clinical reality here?
The reality is that nervous system disorders are massively prevalent. They account for about 10% of all general practice consultations.
10%.
Yeah. And a staggering 20% of acute medical admissions.
Wow.
And here's the most sobering statistic.
Wow.
They are responsible for the majority of chronic physical disability globally.
So the old idea that neurology was just about diagnosing things you couldn't treat is completely outdated.
Completely. Modern therapies for stroke, for MS, for movement disorders, they are effective, but, and this is the crucial part, they demand an accurate, timely diagnosis.
So our ultimate mission here is to empower you to look at a patient's symptoms and immediately start to form a hypothesis.
A firm idea of both the site and the nature of the pathology.
Okay, so we'll anchor the functional anatomy, nail the clinical examination anchors, dive into the investigative techniques, and outline the key clinical syndromes.
Let's get right into it.
Let's not waste any time. We are jumping right into segment 1, the blueprint and the wiring. We're going to start at the cellular level. Think of this as the hardware installation phase. We're calling this Anchor 1, the support crew, and the wires.
Right. So every single piece of neurological function relies on that specialized unit, the neuron.
It receives input via its dendrites and then transmits output via the axon.
And that output is the action potential. Simple as that.
But the neurons are the stars of the show, right? They're the ones doing the work.
They are, but they are incredibly fragile. They're metabolically demanding, and they simply cannot perform their function without a robust, dedicated support system.
And that would be the glial cells.
The glial cells. Davidson's defines 5 key types, and you really need to know the role of each one.
Okay, let's start with the astrocytes. I think of them as the structural scaffolding, sort of holding the whole architecture in place.
That's part of it, for sure, but their role is so much more sophisticated than just support.
Okay.
They are biochemical controllers. They manage the entire extracellular environment, rapidly mopping up potassium ions that get released during action potentials.
Why do they do that?
To prevent neural hyperexcitability. Too much potassium floating around, and the neurons start firing uncontrollably. They also regulate neurotransmitter concentrations.
But their absolute key function, the one thing we need to anchor, is what?
It's that their foot processes wrap around the small blood vessels, creating this crucial, highly selective barrier.
The blood-brain barrier, or BBB.
The BBB. It's truly the brain's VIP security system. It decides which molecules get into the central nervous system.
And maintaining that selective environment is so vital because the brain just can't handle fluctuations.
Exactly. The rest of the body can handle inflammation, infection, or sudden electrolyte shifts. In the CNS, that can be catastrophic. The BBB ensures stability.
Okay, so that's structure and security. Next, we need speed, insulation for the signal.
Right, and that brings us to the oligodendrocytes. These are the specialized cells that form and maintain the myelin sheath, but specifically in the central nervous system.
So in the brain and spinal cord.
In the brain and spinal cord. Their job is all about ensuring fast, consistent signal propagation.
And if we step outside the CNS into the peripheral nerves, that same job of myelination is done by a different cell.
A different cell, same job.
Yeah.
That's the Schwann cell. It's just a different neighborhood.
Okay, so astrocytes for support in the BBB, oligodendrocytes, and Schwann cells for myelin. What's left?
The final 2 are basically the cleaning and lining crew. Microglial cells are derived from the immune system's monocytes and macrophages.
So they're the CNS's dedicated cleanup crew.
That's a perfect way to put it. They phagocytose foreign invaders, fight infection, and remove damaged neuronal debris.
And the last one?
Ependymal cells. These are just the epithelial lining of the cerebral ventricles, and they help circulate the cerebrospinal fluid.
Okay, that's the static anatomy. The hardware. Now, how does this sophisticated hardware actually communicate?
We move from structure to dynamic chemistry, neurotransmission.
Take electrical handshake.
Exactly. The primary function of a nervous system is computation. It's maintaining homeostasis while also generating these incredibly complex outputs like thought and movement.
And all of that relies on successful communication across the synapse.
Entirely.
So the process begins when all the synaptic inputs at the dendrites add up and they're strong enough to trigger an action potential.
Right. Once that impulse races down the axon, the real action starts when it hits the terminal.
So what happens there?
The action potential depolarizes that presynaptic terminal, and that wave of depolarization triggers the opening of voltage-gated calcium channels.
So the influx of calcium, that's the signal.
It's the immediate molecular signal that tells the presynaptic terminal to release its payload.
And the Cat2 plus entry causes these little synaptic vesicles, which are packed with neurotransmitters,
In Davidson's notes, there are at least 20 different known types.
to fuse with the membrane and just dump their contents into the synaptic cleft.
Precisely. And what happens next? The fate of those neurotransmitters dictates the entire effect. And this is where we need to anchor the crucial difference between the two main receptor types.
Because this is essential for understanding pharmacology and brain plasticity.
It really is.
So you have the immediate acute effects, and then you have longer-term modulation. Let's start with acute.
Okay, the immediate effects happen when the neurotransmitter binds to ligand-gated ion channels.
Ligand just means the molecule binds to it.
Right, it binds, and that immediately opens the channel, allowing ions to flood in. This rapidly changes the electrochemical gradient, either exciting the next neuron or inhibiting it.
So it initiates the next action potential almost instantly.
Instantly. It's incredibly fast.
But where it gets really interesting for long-term function, and this is the basis for things like memory and learning, is the second type of receptor.
The metabotropic receptors.
Yes.
These are different. They don't open channels directly. They bind the neurotransmitter, but then they activate these complex intracellular second messenger systems, often involving G proteins.
So instead of just opening a gate, they're starting a whole cascade inside the cell.
They're modulating the cell's internal machinery. They can affect gene expression, synthesize new ion channels, or just change the neuron's sensitivity for the future.
Ah, so this requires time. This isn't instantaneous.
Not at all. Sometimes hours or days. But it fundamentally alters the future behavior of that synapse.
So the ligand-gated channel is like a quick text message, an immediate command.
Right.
Whereas the metabotropic receptor is more like a company-wide policy meeting that changes the operating structure for months to come.
That is a fantastic analogy. And that modulation of gene expression is exactly what long-term memory formation relies upon.
And critically, because this whole mechanism is so complex, from making the neurotransmitters to releasing them, binding them, and cleaning them up,
it is highly amenable to pharmacological manipulation. Most of the psychiatric and neurological drugs we use, from SSRIs to L-DOEA for Parkinson's, they're all targeting different points in this exquisite system.
Okay, now let's zoom out. We moved to the gross anatomy. We structured the brain as a major corporation before. Let's use that to understand functional specialization.
Perfect.
Oh.
The cerebral cortex is the executive floor. The complexity of its folding and specialization is really what defines our higher function.
We can think of the anterior half, so everything in front of the central sulcus, as the doing half.
The doing half. Executive functions, planning, motor execution, behavioral control, it's all up front.
And the posterior half, everything behind the central sulcus, is the interpreting half.
Right. Perception, processing sensory input, language reception, spatial awareness, that's all in the back.
And this function is also lateralized. It's not symmetric.
Not at all. In about 90% of the population, the left hemisphere is dominant. It's the language processor, the logical, analytical side.
And it coordinates fine motor control, speech, and verbal memory.
Mm-hmm.
Now, a key clinical nuance for exams. If you see a left-handed patient, you can't just assume their right hemisphere is the dominant one.
No, you can't. It's actually closer to a 50-50 split on whether the left or the right hemisphere takes on that primary language and analytical role in left-handers.
Okay. Let's walk through the lobar function. Let's talk about what happens when these different departments fail. This is localization at its highest level.
Let's do it.
The frontal lobe, we called it the CEO's office. It handles planning, abstract thought, behavior, and movement.
And if this lobe is damaged, the consequences are profound. They often affect the very core of a person's personality and drive.
What does that look like clinically?
You see dramatic personality changes, Often, a patient becomes very disinhibited or even shows antisocial behavior because that internal filter is just gone.
And they lose motivation.
A severe lack of initiation, apathy, or abulia. Then you have the specific localizations. Expressive dysphagia is in Broca's area. Of course, the primary motor strip is there, so damage leads to contralateral hemiparesis.
And don't forget the specialized motor areas for micturition that can cause incontinence. So the frontal lobe is so much more than just movement.
It's the essence of the person.
Okay, moving back to the parietal lobe, the interpreter. Here, we have to constantly anchor the difference between the dominant and non-dominant side.
We do. The dominant parietal lobe, which is usually the left, is the analytical hub. It integrates sensory information with high-order language and mathematical skills.
So damage there is going to cause what?
Language problems or dysphagia. The inability to perform calculations, which is acalculia, sensory loss, of course, and apraxia, difficulty executing learned movements, even though the motor function is intact.
Now, for the most famous clinical presentation, damage to the non-dominant parietal lobe, usually the right. This lobe is all about spatial awareness and body image.
And damage here is profoundly disorienting. The patient exhibits neglect of the contralateral side.
And let's be clear, they don't just fail to see the left side of space if the right lobe is damaged.
No, they literally fail to recognize its existence. It's a fascinating and devastating deficit.
So you might see a patient only shave the right side of their face.
Or only eat the food on the right side of their plate. Or the classic test, you ask them to draw a clock, and they'll only draw the numbers from 12 down to 6, completely ignoring the left side of the circle.
That image is so powerful, it really demonstrates the severity of that deficit. That's what makes the non-dominant parietal lobe so high-yield clinically.
Absolutely.
Okay, next, the temporal lobes. These are tied to hearing, memory, and emotion.
Right. And again, dominant versus non-dominant is key. The dominant temporal lobe houses Wernicke's area, which is all about verbal comprehension.
So damage there means receptive aphasia. The patient can hear words, but they can't process their meaning. And you'll see impaired verbal memory.
And the non-dominant temporal lobe processes nonverbal memory, emotion, musical pitch. Damage here impairs a person's ability to recognize melodies, and it affects their nonverbal memory.
Which can be a surprisingly profound deficit for someone who relies on music or nonverbal cues.
Very much so.
Finally, the occipital lobes. These are the easiest to localize.
The visual processing center. Damage produces corresponding visual field defects, most often a homonymous hemianopia, which is loss of vision in the same half of the visual field in both eyes.
Okay, medical student, let's solidify this. Time for our first check-in.
The localization challenge.
Here's the scenario. A patient suddenly loses the ability to tie their shoes, which is a form of apraxia. They're struggling to recognize familiar objects, that's agnosia. And when you ask them to draw a daisy, they only complete the petals on the left side of the paper, completely neglecting the entire right side of their visual space.
Okay.
Where is the lesion and which is the dominant hemisphere?
All right. So the inability to draw, that constructional apraxia, combined with that striking right-sided neglect that points unequivocally to damage in the spatial awareness center.
Which is where?
The non-dominant hemisphere.
Yeah.
And since they're neglecting the right side of space, the lesion must be in the non-dominant parietal lobe, which in this case would be the left, assuming the patient is left-handed with right hemisphere dominance or length.
Wait, let's clarify that. If they are neglecting the right side of space, the lesion is on the opposite side.
You're right, my mistake. If they are neglecting the right side of space, the lesion is in the left hemisphere. And since neglect is a function of the non-dominant hemisphere, that would make their left hemisphere the non-dominant one. So a left-handed individual.
A good clarification. The key point is neglect points to the non-dominant parietal lobe, and the lesion is contralateral to the neglected space.
Exactly.
If that difference between dominant parietal functions, language and calculation, and non-dominant functions, spatial awareness and neglect, isn't instantly clear to you, please rewind and listen to that lobe breakdown again. It is an absolute cornerstone of neurological localization. Okay, let's move beyond the cortex. Now we're getting into the pathways and supporting systems that actually generate and coordinate movement and process sensation.
Segment 2.1 is probably the most essential clinical distinction for your physical exam. We're calling this Anchor 2, the UMN versus LMN distinction.
UMN versus LMN, upper motor neuron versus lower motor neuron.
Think of the upper motor neuron, UMN, as the executive. It's in the cortex, and it initiates the conscious plan for movement.
These neurons travel down the pyramidal tract, and crucially, they decussate or cross over in the medulla.
Right, at the junction between the brainstem and the spinal cord. Then they descend in the lateral columns and finally synapse onto the LMN.
So what happens when that UMN is damaged, say, by a stroke that happens above the medulla? The executive order is cut off.
And this leads to the famous UMN signs, which are anchored by one key word, spasticity.
Okay, what does that mean?
A UMN lesion basically releases the lower circuits from inhibitory input. It's like taking the brakes off. This leads to hypertonia, or increased muscle tone.
And this presents as the characteristic clasp knife phenomenon.
Yes, where you feel this initial high resistance to passive movement, but then it suddenly melts away with sustained effort. You also see brisk reflexes, or hyperreflexia, and the pathological release of the extensor plantar response.
The positive Babinski sign.
The positive Babinski.
Now, here is the counterintuitive clinical nuance that we really have to highlight because it catches students out all the time. If the UMN lesion is acute, say right after a stroke, you don't see spasticity immediately, do you?
You do not. Correct.
Yeah.
The initial injury leads to a period of flaccid paralysis and hyperreflexia. This is often called spinal shock.
And that can last for days or weeks.
Days or even weeks. It's a temporary state of system failure. The classical spasticity and hyperreflexia, that's the result of the lower circuits becoming chronically hyperexcitable. It's a chronic adaptation, not an acute sign.
That delay is so critical because it means you can't rely on spasticity for acute localization.
You can't.
Okay, so that's the UMN. Now for the lower motor neuron, LMN, the factory worker.
Right. The LMN cell bodies are located in the anterior horn of the spinal cord. Their axons travel all the way out to the muscle.
So if the LMN is damaged, the muscle loses all of its input.
And it wastes away. This is anchored by the word flaccidity.
So the LMN lesion signs would include severe weakness or paralysis.
Rapid muscle wasting, or atrophy, due to denervation. You also see spontaneous muscle group twitching, which are called fasciculations.
And you'd see reduced tone, so flaccidity, and a complete absence of reflexes.
Areflexia. The contrast with UMN lesions, no wasting brisk reflexes, that has to be automatic for you now.
Okay, but movement requires more than just initiation. It needs coordination.
Right. Enter the extrapyramidal system. This is middle management, the basal ganglia, and all the related circuits.
And this system regulates muscle tone, posture, and ensures the smooth initiation of movement. So if this system fails, the characteristics are completely different from either UMN or LMN signs.
Completely different. The tone abnormality is crucial. You see increased tone, but unlike spasticity, it's continuous and uniform throughout the entire range of passive movement. It doesn't matter how fast you move the limb.
And that's called lead pipe rigidity.
Yes. And if that resistance is overlaid with a tremor, it feels like a catch and release, and it becomes cogwheel rigidity, which is characteristic of Parkinsonism.
The other hallmark of basal ganglia failure is bradykinesia.
Slowness. Slowed, clumsy movements that characteristically get smaller and slower with repetition. Think of someone trying to rapidly tap their fingers, and the taps just become smaller and slower.
That, along with arresting tremor and postural instability, localizes the problem firmly to the extrapyramidal system.
Exactly.
Finally, we have cerebellum. This is the quality control department.
It doesn't initiate movement. It fine-tunes it, coordinates it, and ensures accuracy. It's vital for planning learned skills, for balance, and for clear speech articulation.
The key anatomical anchor for the cerebellum is that its lesions produce deficits on the same side of the body.
Ipsilateral. This is a massive distinction from the cortical UMN lesions, which are contralateral.
So what do cerebellar signs look like?
They're all about a lack of coordination, or ataxia. In the limbs, the classic sign is intention tremor.
Meaning the tremor appears or gets worse as the limb gets closer to its target.
Right. It reflects a failure of fine-tuning accuracy. You also see dysmetria, which is past-pointing or undershooting a target.
And dysdiadotokinesis.
The inability to perform rapid alternating movements smoothly. You'll also see nystagmus, which are abnormal eye movements, and explosive slurred speech or dysarthria.
And if the central part of the cerebellum, the vermis, is affected, you get a profound gait ataxia. Okay, let's test the pathway logic. A patient presents acutely after a traumatic brain injury.
Okay, number 2.
They have brisk reflexes, ankle clonus, and a clearly positive Babinski sign on the left side. But currently, they're completely flaccid and have no muscle wasting.
Okay.
What type of lesion is this, and where is the anatomical site?
All right. The hyperreflexia and the Babinski sign are immediate, undeniable localizers for a UMN lesion.
Right.
The flaccidity suggests that the lesion is acute. We're still in that phase of spinal shock.
And since the weakness is on the left,
And the pyramidal tract crosses at the medulla, the lesion must be in the right cerebral hemisphere, somewhere superior to that point of decussation.
perfect. If you hesitated on the acute flaccidity phase or the crossing point, please review that UMN section now. Okay, let's move from motor to sensation. Information about the world travels up the spinal cord through two very distinct pathways.
And they cross at dramatically different levels.
Okay.
This distinction is absolutely crucial for localizing spinal cord damage. We call this anchor 3, the dual highway,
Let's start with the fast lane, the dorsal column.
or the medial lemniscus pathway. This carries the complex, fine-tuning data, proprioception, where your body is in space vibration sense, and two-point discrimination.
So accurate touch.
Accurate touch. These sensory fibers enter the spinal cord and immediately ascend on the same side.
Ipsilaterally.
They stay on the same side. They bypass all the lower processing centers, and they don't synapse or cross until they reach the nuclei way up in the upper medulla.
And that design maximizes speed and fidelity for critical data like balance.
It does. Now, contrast that with the local road, the spinothalamic tract.
This is the basic survival pathway.
Pain and temperature. Nociception. When these fibers enter the spinal cord, they synapse immediately in the posterior horn, and critically, they cross the midline right there in the spinal cord.
And then they ascend contralaterally in the anterolateral tract.
Right, so the immediate clinical significance of this opposing anatomy is profound. We see what's called dissociated sensory loss in spinal cord injuries.
Particularly in Brown-Séquard syndrome, which is damage to one half of the spinal cord.
So below the level of the lesion, the patient will lose pain and temperature sensation on the side opposite the lesion.
Because the spinothalamic tract already crossed.
Right. And at the same time, they will lose proprioception and vibration on the same side as the lesion.
Because the dorsal column has not yet crossed, you're dissociated, losing different senses on different sides.
Exactly. That is a classic exam question, and it demonstrates exactly why knowing the crossing points is essential for finding the spinal level.
We should also touch on dermatomes, the area of skin supplied by a single spinal nerve root.
While they're not as precise as an MRI, they still provide that initial clinical roadmap to find the level of an injury.
Okay, one last sensory anchor back in the brainstem, the balaclava sign.
Ah, yes. The trigeminal nerve supplies facial sensation. The sensory input from the core of the face travels a short distance down the brainstem before it crosses.
But the input from the back of the face around the ears and the scalp, that descends much further.
Much further into the upper cervical spinal cord before it finally synapses.
So if a lesion occurs low in the brainstem, it only catches those long descending fibers.
And the result is sensory loss that looks like the patient is wearing a balaclava helmet, sparing the central part of the face. It's a highly specific presentation that is pure anatomical localization gold.
All right, moving on to segment 3. We're transitioning from the physical exam hypothesis to the confirmatory diagnostics.
We're looking inside and listening to the electrical signals.
Let's start with neuroimaging. This is Anchor 4, the photographer's toolkit.
Structural imaging is the first step. And we have two key modalities, CT and MRI.
CT, computed tomography, is the workhorse.
Fast, cheap, and widely available.
The primary clinical advantage is that speed and its excellent visualization of dense structures.
Exactly. CT is the first-line imaging for acute head trauma to exclude a hemorrhage or a skull fracture. It's also great for calcification, atrophy, and looking at bone, especially at the skull base.
But it struggles with soft tissue contrast.
It does, which brings us to MRI, magnetic resonance imaging. This is the modality of choice for soft tissue detail.
It provides these high-quality images of the cortex, the white matter, the cranial nerves.
And the posterior fossa, the back of the brain where the dense temporal bone often causes a lot of artifact on CT scans.
So MRI's high sensitivity makes it the gold standard for spotting subtle changes. Demyelination, inflammation, small tumors.
It's a test of choice.
The trade-off is, of course, expense, time, and contraindications. You can't use it on patients with older pacemakers or certain metallic implants.
Right. And for the student, understanding the MRI sequences or the camera filters is crucial for interpretation.
Okay, let's nail down the 3 core sequences. T1.
P1 is for anatomy. Think of T1 as anatomically correct contrast. Gray matter is gray, white matter is white, and CSF is always black.
So hypointense?
Hypointense. T1 shows structure clearly. It's excellent for evaluating atrophy.
Okay, then T2.
T2 is for pathology. T2 basically reverses the contrast, making water and pathology like edema, inflammation, or tumors appear bright, hyperintense.
Now, CSF is also water, so on T2, CSF is white.
It is. Gray matter is bright white, and white matter is dark gray.
So the problem arises when the pathology, like an MS plaque, is located right next to the bright CSF in the ventricles.
The intense signal from the CSF can just wash out or completely obscure the lesion. This led to the development of T2 flare.
Fluid-attenuated inversion recovery.
Right. Flare is essentially a T2 scan, but we use a specialized radiofrequency pulse to dampen the signal from free water from the CSF.
So it makes the CSF appear black.
It makes it black while keeping the signal from the pathological water and the lesion bright.
This sounds like a breakthrough for finding MS plaques.
It was. The ability to distinguish between inflammation near the ventricle and the ventricle itself is precisely why flare is so essential in inflammatory neurology.
And beyond these structural images, there are advanced techniques like fMRI and MR spectroscopy,
which can assess metabolism and characterize tissue based on its chemical composition. Is it a tumor, an abscess, or an infarct?
Okay, now let's listen to the signals. The EEG, electroencephalography.
This records electrical activity from the surface of the brain using scalp electrodes. The normal resting background rhythm, when your eyes are closed, is the 8 to 13 hertz alpha rhythm.
What's the main utility of the EEG?
It's really in epilepsy. It helps us classify seizure type by distinguishing between generalized epileptic discharges, which are symmetric and affect the entire cortex, and focal sharp waves, which are localized to one region. And that informs treatment and localization.
We also use evoked potentials, EPs.
These measure the nervous system's response latency to a standardized sensory stimulus, visual, auditory, or somatosensory.
And the visual evoked potentials, or VEPs, are particularly high-yield clinically.
They are. You stimulate the retina with a checkerboard pattern and measure the time it takes for that signal to reach the visual cortex. If the patient has had a past demyelinating event, like optic neuritis from MS, that signal will be significantly delayed.
Even if their current visual acuity is normal.
Even if it's normal. It provides evidence of prior, often subclinical, damage.
Finally, we have nerve conduction studies, NCS, and electromyography, EMG.
These are for analyzing peripheral function. NCS measures the speed and amplitude of nerve signals. It helps you determine if a neuropathy is primarily axonal, meaning loss of nerve substance, or demyelinating, meaning loss of insulation.
So reduced speed.
Reduced velocity, exactly.
Yeah.
EMG, on the other hand, inserts needles directly into the muscle to assess the electrical activity of the muscle fibers themselves.
And that helps differentiate problems originating in the muscle, a myopathy, from problems in the nerve, a neuropathy.
That's the key distinction.
Our final major diagnostic tool is the lumbar puncture, LP, accessing the CNS environment via the CSF.
Usually performed safely between L3 and L4.
But safety first. The LP is contraindicated if there's any clinical suspicion of raised intracranial pressure.
RICP. Papilledema on fundoscopy is the classic sign, though it's not always present. The risk here is profound.
Why is that?
If you draw fluid from below when the pressure is high above, you create a pressure gradient that can push the brain contents downward, leading to deadly coning or herniation.
Okay, so if the pressure is safe, the initial visual check of the fluid is crucial.
Normal CSF should be crystal clear and colorless. We check for xanthochromia, a yellow discoloration of the supernatant after the CSF is centrifuged.
And that color is caused by the breakdown products of hemoglobin.
Right, which indicates that blood has been in the CSF for at least a few hours. It's a classic sign of a subarachnoid hemorrhage.
Now, for the core chemical analysis, students have to commit these 4 classic patterns to memory.
They do.
Let's start with acute bacterial meningitis.
Aggressive. The bacteria are consuming glucose, so you see very low glucose. The host immune response is massive, leading to very high protein and a very high white cell count, predominantly neutrophils.
Polymorphs.
Right.
Okay, then viral meningitis.
Typically less severe. The virus doesn't consume glucose, so the levels are normal.
Yeah.
Protein is only slightly raised, and the cell count is moderate, but this time it's predominantly lymphocytes.
And for chronic infections like TB or fungal meningitis.
You often see a picture somewhere in between, high protein, a marked reduction in glucose. But the cell count is usually chronic, so lymphocytosis dominates.
Finally, for inflammatory conditions like multiple sclerosis,
The CSF might look deceptively normal, but specialized analysis is performed for oligoclonal bands, or OCBs.
this is evidence of IgG antibodies that are synthesized intrathecally, meaning only within the CNS.
And the presence of OCBs is highly supportive of an MS diagnosis.
Okay, time for our third check-in. You have an acutely febrile patient with severe neck stiffness. You carefully perform an LP. The results show normal glucose, moderately increased protein, and a white cell count of 250, 90% of which are lymphocytes. What is the most probable diagnosis?
The combination of normal glucose, moderate protein, and that strong lymphocyte predominance points strongly toward viral meningitis.
But there's a catch, isn't there?
There is. We always have to keep in mind that a partially treated bacterial meningitis can suppress the neutrophil count and mimic this exact pattern. So while viral is most likely, the clinical context, imaging, and probably empirical treatment are still necessary.
If you missed that lymphocyte versus neutrophil distinction for infection types, please rewind to this segment.
All right, we are shifting now to applying all this foundational knowledge.
The history is your map, the physical exam is your compass. We have to learn to spot the patterns in the common complaints.
Let's start with headache. While most are benign, the big red flag is the acute presentation.
The thunderclap headache. Pain that reaches its maximal intensity within 60 seconds. That demands immediate investigation to exclude a subarachnoid hemorrhage. Okay, let's talk about the 3 common primary headache types.
They're highly specific. Tension headache is characterized as a non-throbbing, dull, generalized ache. Patients often describe it as a tight band or pressure around the head.
And crucially, it's not usually disabling.
Right, and it's rarely associated with photophobia or vomiting.
Migraine, on the other hand, is the severe one.
Typically unilateral, throbbing, and associated with movement exacerbation, photophobia, phonophobia, and nausea or vomiting. About 20% of people experience an aura.
And the key to the migraine aura is that it consists of positive phenomena.
The addition of symptoms, exactly. And it evolves gradually over 10 to 60 minutes. The classic image is the shimmering zigzag lines, the fortification spectra, or the slow spread of sensory tingling across a body part.
And this is a critical distinction from a transient ischemic attack, or TIA.
Yes. A TIA mimics a stroke. It causes negative symptoms, a sudden loss of vision, a loss of power. And the onset is abrupt, not gradual.
So that temporal and qualitative difference is your main clinical differentiator.
It is.
Then you have the excruciating cluster headache.
These are short-lived but intensely severe, strictly unilateral headaches that occur in cyclical clusters.
They often wake the patient at the exact same time every night.
The alarm clock headache. And they're accompanied by striking ipsilateral autonomic symptoms, tearing, nasal congestion, or a droopy eyelid.
Finally, trigeminal neuralgia. This is purely facial pain.
Purely facial. It presents as brief, repetitive, intensely severe, lancinating pain like an electric shock, usually localized to the V2 and V3 divisions of the trigeminal nerve.
And it's unique because it's often triggered by non-painful stimuli.
Right, like eating, speaking, or just a light touch on a trigger zone.
Okay, let's move to movement disorders.
Okay.
This section localizes pathology to the basal ganglia circuits. The cardinal hypokinetic, or too little movement disorder, is Parkinsonism.
Parkinsonism is a clinical syndrome defined by 4 primary symptoms, though you don't need all of them to be present. The hallmark is bradykinesia.
Slowness of movement, especially that decrementing nature of repetitive movements. The steps get smaller, the writing gets smaller.
Micrographia. Second is the rest tremor. Typically unilateral at the onset, a slow, low-frequency pill-rolling motion.
And it's present when the limb is relaxed, but it's often abolished momentarily by voluntary movement.
Correct. Third, rigidity. The stiffness we discussed earlier, usually lead pipe or cogwheel rigidity. And finally, postural instability, which leads to falls.
Okay, on the hyperkinetic, or too much movement side, we need distinct definitions. Chorea.
From the Greek for dance. It refers to abrupt, brief, irregular, non-stereotyped movements that seem to just flow randomly from one body part to another. Huntington's disease is the classic example.
Dystonia.
This is a sustained or intermittent muscle contraction which causes twisting and repetitive movements and abnormal postures. Think of cervical dystonia causing torticollis or blepharospasm in the eye.
Then myoclonus.
An incredibly brief, isolated, lightning-fast, shock-like muscle jerk This could be physiological, like the hypnic jerks you get as you fall asleep, or pathological.
And finally, tics.
Tics are stereotyped, repetitive movements or sounds that are unique because, unlike chorea or myoclonus, they are briefly suppressible by conscious effort.
Even though that effort causes significant internal tension.
Right. That suppressibility is the clinical anchor for tics.
Okay, time for check-in number 4. A patient is undergoing assessment for Parkinsonism. During passive movement of their forearm, you detect resistance that is uniform across the entire range of motion. There's no sudden giveaway. What type of rigidity is this, and what key structure is primarily involved?
That uniform resistance, regardless of speed or joint angle, is the definition of lead pipe rigidity.
And it localizes firmly to
the extrapyramidal system, meaning pathology in the basal ganglia circuits.
If you were thinking clasp knife, remember that is velocity dependent and it characterizes UMN spasticity.
A critical difference.
Okay, let's talk about weakness and gait abnormalities. Gait assessment is pure clinical neurology. You have to learn to read the walk.
You do. If the cerebellum is affected, the patient exhibits cerebellar ataxia. A wide-based, drunken, unsteady gait. They're struggling with balance and coordination.
And their limbs will show that intention tremor we talked about.
If the issue is proprioceptive, a loss of joint position sense from damage in the peripheral nerves or the dorsal columns, you see sensory ataxia.
The patient is unsteady, particularly in the dark or when they close their eyes.
That's a positive Romberg sign. And they often resort to this high-energy, heavy stamping gait to try and enhance the sensory input they're getting from the ground.
For motor nerve issues, we see foot drop.
This happens when the LMNs supplying the ankle dorsiflexors fail. So to avoid tripping, the patient compensates with a high stepping gait, lifting their knee excessively.
And that results in a characteristic slapping noise as the foot hits the floor.
It does. Finally, a waddling gait results from proximal muscle weakness, typically a myopathy or muscle disease. The patient can't adequately stabilize their hip during walking, so they have this exaggerated side-to-side trunk sway to maintain balance.
Okay, let's anchor the most common facial weakness syndrome, Bell's palsy.
An idiopathic acute LMN lesion of the 7th cranial nerve, the facial nerve.
The critical localization anchor here is what?
Because it's an LMN lesion, it affects all the muscles of facial expression on that side, including the forehead. The patient cannot wrinkle their forehead on the affected side.
And this is vital to distinguish it from a UMN lesion, like a stroke,
which typically spares the forehead due to bilateral cortical innervation.
And the treatment for Bell's palsy relies on starting glucocorticoids early and ensuring eye protection with artificial tears.
Because the eye often can't close properly, and that risks corneal abrasion.
We need to be precise in our language when describing communication deficits. We're looking for the difference between a mechanical problem and a content problem.
Right. Dysarthria is the articulation problem. The language content is intact. The patient knows exactly what they want to say, but the motor output system, the lips, tongue, larynx, brainstem, cerebellum, is failing.
So speech is poorly articulated, slurred, or slow.
Right. Dysphagia, or aphasia, is the language content problem, and it always localizes to the dominant hemisphere, usually the left.
We use two classic types, fluent or receptive aphasia.
This localizes to vernix area in the temporal lobe. Comprehension is severely impaired. The patient speaks easily and fluently, but their speech is often meaningless, filled with nonsensical word substitutions.
Paraphasia.
Or entirely invented words.
Neologisms.
Right.
And non-fluent or expressive aphasia.
This localizes to Broca's area in the frontal lobe. Here, comprehension is relatively intact, but speech production is agonizingly slow, halting, and effortful. The output is often telegraphic, only including the essential nouns and verbs.
So what's the clinical takeaway here?
Dysphagia is often missed, especially in a busy acute setting. Always test specific language functions in a patient who seems confused, because receptive aphasia makes them sound confused. But it's a specific language disorder, not generalized disorientation.
Okay, we've established the anatomy and the clinical presentation anchors. Let's dedicate this final segment to diving deep into 3 critical, specialized syndromes that every medical student must recognize.
Let's do it. We start with multiple sclerosis, MS, the prototype demyelinating disease.
Its diagnosis relies entirely on demonstrating that the inflammatory process has occurred in different places at different times.
That is the anchor. Dissemination in time and space. Clinically, this means the patient must have had at least 2 episodes of neurological dysfunction that you can attribute to different anatomical sites.
For example, optic neuritis followed months later by a sensory deficit in their leg.
Exactly. And MRI is indispensable here because it can show evidence of new, active lesions and old, inactive lesions at the same time.
So it can fulfill the dissemination criteria even if the patient has only had one clinical attack.
Precisely. And as we mentioned, the CSF typically contains those oligoclonal bands, which strongly supports the diagnosis.
And MS treatments have been revolutionized, so early diagnosis and starting disease-modifying therapies are vital to slow the disease progression.
They are. But we need to distinguish MS from its dangerous imitators.
The most important differential is neuromyelitis optica spectrum disorder, NMOSD.
Right. While MS is characterized by multifocal, smaller plaques, NMOSD typically presents with severe, often bilateral, optic neuritis or a specific type of spinal cord lesion,
Known as longitudinally extensive transverse myelitis, or LETM.
which is a lesion that spans 3 or more vertebral segments. That long lesion is the radiographic anchor for NMOSD, and the pathogenesis is distinct.
It often involves a specific antibody.
Yes, the majority of NMOSD cases are associated with antibodies against the astrocytic water channel aquaporin 4, or AQP4. Finding those AQP4 antibodies in the serum is highly predictive.
And this distinction is critical because some treatments for MS can actually make NMOSD worse.
Much worse.
Finally, we have to mention the rapidly growing field of autoimmune encephalitis AE.
This should be a major differential for any acute inflammatory deterioration that presents with neuropsychiatric symptoms, seizures, or new movement disorders.
AE is often associated with a preceding infection or sometimes an underlying malignancy.
A paraneoplastic syndrome. A classic presentation is limbic encephalitis, where inflammation targets the limbic system, the hippocampus. Clinically, this leads to profound memory disturbance, emotional and behavioral changes, and seizures.
And the antibodies are becoming more specific. Limbic encephalitis is strongly linked to antibodies like LG1 and CSPR2.
And the highly severe NMDAR encephalitis, which causes intense autonomic instability and bizarre movements, is often associated with an ovarian teratoma, which just highlights the complex link between the peripheral immune system and the CNS.
Let's move to intracranial mass lesions and pressure, RICP.
Any space-occupying lesion, a tumor, a large hemorrhage, an abscess or impaired CSF outflow can raise the intracranial pressure.
And that pressure causes the generalized symptoms. Headache that's worse on lying down or straining, vomiting that's often projectile, and double vision.
Diplopia. The worry, of course, is that the brain is in a fixed box. It cannot expand. When pressure rises, structures get pushed out of place.
And this brings us back to anchor 6, false localizing signs.
The 6th cranial nerve, the abducens, which controls lateral eye movement, is the most common false localizing sign. It has this long, slender course over the skull base.
So when RICP causes the brain to shift slightly, this long nerve gets easily stretched and compressed,
leading to a unilateral or bilateral 6th nerve palsy. The eye can't abduct fully.
And the sign is false localizing because the pressure is generalized, but the symptom, the diplopia, makes it look like the lesion is right there where the 6th nerve lives.
Right. It's alarming, but it's often survivable if you control the underlying pressure. But the truly life-threatening event is herniation or coning.
This is what we feared when we were talking about the LP contraindication.
The most feared form is temporal or ungual coning. A mass in the hemisphere pushes the medial temporal lobe, the unconed, inward.
And that compresses the midbrain and, critically, the ipsilateral 3rd cranial nerve against the tentorial edge.
And the 3rd nerve carries the parasympathetic fibers for pupil constriction on the outside of the nerve bundle. So compression affects these fibers first,
causing the telltale sign of an increasingly dilated, non-reactive pupil.
This is a severe, time-critical emergency indicating imminent brainstem failure.
And the other form is tonsillar coning,
where the cerebellar tonsils are pushed down through the foramen magnum, compressing the medulla, the home of the cardiorespiratory centers. This leads to rapid respiratory arrest and death.
Okay, we'll close the syndromes with the classic junction disorder, myasthenia gravis, MG.
This disease is defined by its pathophysiology anchor. It's an autoimmune disease, most commonly caused by antibodies targeting the acetylcholine receptors on the post-junctional membrane of the muscle fiber.
So the binding of the antibody just blocks the function of the receptor.
Right. The functional consequence is clear. Since the muscle receives less acetylcholine signal, it fatigues incredibly quickly. This is the fatigable weakness disease.
The clinical features reflect this extreme fatigability. Weakness is intermittent, it worsens throughout the day or after sustained physical effort.
And the ocular, facial, and bulbar muscles are usually affected first. You see fluctuating drooping eyelids, ptosis, double vision, diplopia, and difficulty chewing or swallowing, dysphagia.
A key differentiator is that since the pathology is purely at the junction between the nerve and the muscle,
There are absolutely no sensory symptoms and no CNS involvement. It is purely a motor issue.
diagnosis is confirmed by testing for AChR antibodies. If the weakness is severe and compromises the airway or breathing,
A myasthenic crisis.
it requires immediate intensive respiratory support and acute immunotherapy.
Typically high-dose intravenous immunoglobulin, IVIG, or plasma exchange to rapidly reduce the antibody load.
We have covered a tremendous amount of ground, from the glial support crew to life-threatening herniation. Let's quickly review the high-yield anchors one last time.
Okay. The motor system. UMN equals hyperreflexia, spasticity, and a positive Babinski. LMN equals wasting, fasciculation, and airflexia.
And remember the crucial delay in UMN spasticity,
Yes.
the dual sensory highway. Dorsal column for vibration and proprioception is the fast lane, ascending ipsilaterally to the medulla.
And the spinothalamic tract for pain and temperature is the local road, crossing immediately in the spinal cord.
Imaging filters. T1 is anatomy, CSF is black.
T2-FLAR shows pathology. Water is bright, with full air dampening the CSF signal to reveal those paraventricular lesions, crucial in demyelinating disease.
Facial palsy localization. If the forehead is spared, the lesion is central. It's UMN.
And if there is no forehead sparing, the lesion is peripheral. It's LMN, like Bell's palsy.
Okay, before we conclude, time for one last self-assessment.
Truly reflect on your mastery of these foundational tracks. Could you accurately draw out the full course of the spinothalamic pathway, illustrating precisely where it crosses and where it ascends?
And can you definitively state the anatomical structures implicated by cogwheel rigidity versus the clasp knife phenomenon?
If either of those localization points is hazy, please ensure you rewind and listen to segments 2 and 4 again. Localization is king.
We've successfully navigated the neural architecture, anchored the essential clinical distinctions, and provided clear roadmaps for diagnosis, from imaging filters to CSF analysis.
And the core takeaway remains. Neurology is complex, but it is deeply logical. Every symptom means something, and the goal of the history and examination is always to provide a robust anatomical hypothesis for the site and the nature of the pathology.
That systematic approach is what separates the excellent clinician from the overwhelmed student.
Absolutely.
And as your final provocative thought, tying back to that anatomy of vulnerability we mentioned, why is the simple unilateral sixth nerve palsy the most common false localizing sign of raised intracranial pressure?
And conversely, why does a third nerve, palsy, specifically, that dilated, non-reactive pupil signal, severe, life-threatening temporal coning?
Think about the anatomical path of the sixth nerve long and exposed to stretching versus the vulnerable location of the third nerve where it passes over the tentorium.
Putting it right in the line of fire during a mechanical brain shift. Understanding the difference in anatomical vulnerability is your next deep dive.
That is a perfect challenge to solidify your localization skills. Thank you for diving deep with us. We hope this roadmap helps you master the foundations of clinical neurology.
We'll catch you next time for the next deep dive.